everyone, it's me, Tanya, your host here at the MotherWit podcast. You know I sometimes invite my clients on the show to talk about their birth stories and postpartum experiences, but I want to tell you a little bit more about what those clients and I actually do together. I started MotherWit to help people in the perinatal period achieve their health and wellness goals. That means whether you're hoping to conceive and struggling with high blood pressure or high blood sugar, or you're having trouble managing anxiety or depression in the postpartum period, or maybe you just need support and advocacy between prenatal or postpartum visits, I can help. Get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. I'm looking forward to working with you and maybe having you on the show too. Hi everyone. I'm your midwife, Tanya Tringali. Welcome to the MotherWit podcast, a show about the issues that we, healthcare consumers, and providers face every day as we interact with the medical system. We'll talk about its blind spots, shortcomings, and share the strategies that we can use to feel seen and heard, no matter which side of the table we sit on. I am so excited about our guest today because her specialty is one of my favorite topics to talk about, to think about, and to help people work through. Jessica Lynn is a certified nurse-midwife, health coach, and certified diabetes care and education specialist in New York City. Jessica has lived with type 1 diabetes since childhood and is a mother of two. She is passionate about supporting people with diabetes on their journeys from preconception through pregnancy and beyond, which can be difficult because the metabolic demands pregnancy places on the body are super complex, and our bodies are literally changing every day. Not to mention, there are so many variables that affect glucose control within the body, moment by moment, hour by hour, and day by day. I personally have worked with many MotherWit mamas who have PCOS, gestational diabetes, and type 2 diabetes. I personally have PCOS and a strong family history of diabetes, so I'm passionate about and committed to helping all of us manage these things better. Jessica is too. In the midst of her midwifery career, Jessica was driven to learn more about diabetes, so she worked for 3 years in a diabetes-specific endocrine practice, and she now serves as a hospital-based perinatal diabetes specialist and also provides online education and coaching. Jessica, thank you so much for joining me today.
Thank you so much for having me, Tanya. I'm super excited to talk diabetes with you. And a big shout out to your podcast already with such amazing, diverse birth worker voices on there.
Thank you. Well, that's what I'm going for, trying to cover all the bases, and there's so much to cover, so I should have content endlessly, right? But you are part of that equation. You're someone I've wanted to have on since I started this whole thing, because your work is very interesting to me for a number of reasons. Anyone who knows me knows that I am very passionate about diabetes. I think it comes from a slightly different place than where your interest lies, although I think your interest is very broad at this point as well. So I definitely want you to tell us all about yourself, and I kind of want you to take us a little bit through your history in chronological order, right? So many of us, I don't know if you're one of them, my being a midwife came out of my having a baby, right? My personal story precedes my midwife journey. And then of course there's the things that come in the future. So I don't want to dictate to you, tell me this, tell me that. I just want you to tell me your story, and then we'll dive into diabetes.
Okay, sounds good. I was a biology and, as we called it, women's studies, now gender studies major at UC Santa Cruz. And I knew I wanted to do what was once called women's health. And so I became a nurse midwife about 22 years ago and immediately engaged in full scope public hospital midwifery in New York, which has always been my love. I initially was fascinated with all things normal about it, but I was at the same time seeing myself always drawn, wanting to be involved in high risk, although I don't love that term, birth, high risk pregnancy, high risk birth, because deeply I felt that all people should have access to midwifery care. So I was a birth junkie and attended many, like more than 1,000 births by the time I was pregnant with my daughter. And full disclosure, I have type 1 diabetes since I was a child. And so in my head, though, I thought, okay, I'm a midwife. I know what there is to know about birth. I'm an expert in my diabetes. I've got this. And I have access through my privilege, through my insurance, through my education, to all things I needed. That was my feeling going into it. And was I wrong? I was wrong. I felt that despite the fact that endocrinologists were expert at diabetes and that the placenta is actually an endocrine organ, I realized later, they're not experts in the placenta. And high-risk OBs are experts in the placenta, but not necessarily in the very detailed orientation between the placenta and someone's diabetes. Specifically, no one of the group was holistic. And so there was no midwifery presence for me. I got by making a self-study of myself, just delving in to learn as much as I could on a minute-to-minute basis about myself. And it was so anxiety-producing. But I kept that inside, and I took it minute by minute with my blood sugar. And I gave birth, and the opposite of postpartum depression happened to me. I was in postpartum elation for the moment of getting that placenta out of my body. But throughout a period of months after that, I ruminated on this experience that was so surreal. And how I felt like I was a human being cut in two, literally. And I never had a midwife, and no one really understood. So as I ruminated on this, my husband stopped me one day and said, why don't you become the solution? You are the solution if you want to be. And I thought about that for a while. Do I really want to be that? But I decided eventually to, after 1,400 births, I decided to take a job in an endocrine practice, a diabetes-specific private endocrine practice. So I actually worked in endocrine for 3 years, and because it wasn't enough to know I'm a one human. It wasn't enough to know my diabetes. I needed to know the diabetes of many, many people, of many pregnant people, many non-pregnant people with all different kinds of diabetes. And it was an incredible, incredible experience to get to work in endocrine for 3 years. So I became a certified diabetes care and education specialist, and I tremendously missed public hospital midwifery. So once I did that, I went back to my public hospital and started to work in high-risk OB, and eventually saw all people with diabetes and pregnancy at my hospital. And I am the perinatal diabetes specialist. I work within a group of people, including doctors, including midwives, our MFM, Dr. Schiffman, and nurses, and provide more holistic care for this group. In that context, I see myself as a remover of barriers. That is what I see myself suited to do with my own privilege, with my own private and public hospital oscillations, where I go to a private institution, learn as much as I can, and then come back to the public to try to remove the barriers and improve the care and make it more like the private care. So that is always my goal there. I also started to write guidelines for the 11 public hospitals in New York. I don't want to glorify that. It was a job that no one wanted to do, and I was perfect for it. So I did it.
Well, that's why you should glorify it, because you did something that nobody else wanted to do and, quite frankly, probably couldn't do. So as grueling as that may have been, you did something profound.
Well, wait till they get revised. I'm working on that now. They're actually outdated. I'm working on it.
Isn't that the problem with guidelines? They always get outdated. By the time you're done writing them, they're outdated and you're working on the next one. It's terrible.
Yes. And when you're type A, they're never done. So
Yeah.
it's a bit painful, actually. And then what I also painfully remember learning is that no one actually sits down to read guidelines. That is not what happens. And so one must, and I hated this idea, I hated public speaking, but one must speak. And so I began to do that out of necessity to communicate what was in the guidelines. So I started to speak at the public hospitals, at other hospitals, in conferences, and at NYU and Columbia. And actually held a conference on perinatal diabetes, which really had never happened in New York City at NYU, and brought together thought leaders in diabetes. Actually, this is interesting because usually if you go to a high-risk OB conference, there's all people focused on pregnancy and there's maybe one lecture on diabetes. This was all people focused on diabetes through the lens of a pregnancy. So it was a different angle and it was amazing. Now I also do a little something else which has been missing from the public hospital midwifery, which is doing some coaching and online education for people with specifically type 1 diabetes from preconception, where they're really still missing so much information that I learned through my own personal journey and through the journeys of all the other people I've worked with since then. So I am doing that, and I'm working on some more of that kind of online education for a broader group of people with gestational diabetes and type 2 diabetes as well. So that's sort of on the in the future. So that's what I do.
Wow. Okay, so I knew some of that, right? But like the bullet points, I didn't know the story behind it. And I'm just even more impressed than I was before. It's so freaking cool what you're doing. And I can relate to some of it, right? With my like weird niche expertise being fitness stuff, I hear you. Nobody reads the guidelines. Nobody, like all those things. I'm like, word, I hear you. This is the truth. So
Totally.
yeah, it's a world when you specialize in something, I think especially as a midwife, you find yourself having to just get on your soapbox over and over and over again just to get heard by a small number of people. But here we are on this podcast. This is a great opportunity for both of us. I have so many questions, but I'm going to try to stay organized because I think that we need to start with a bit of a primer on diabetes for our listeners, because diabetes terms are super freaking confusing. Like, what does it mean to be a pre-diabetic? How is that different than being a pre-gestational diabetic? And like these words that kind of overlap, and people get really, really, really confused. I think I have a decent handle on this stuff, but clearly I have a lot to learn from you as well. So I would love it if you would take us through the definition, but feel free to add in, some tidbits that you think are really critical to go right alongside the simple definition so that people get where we're going with this conversation.
Sure. You are right that the terminology is really confusing. I chalk it up, of course, to the fact that some of the names were provided through OB brains and some of the names were provided through endocrine brains, and they sort of didn't realize their overlap. Plus, they were happening at different times. So segue to prediabetes, which is the most common of all the terms I can define. However, it's the most recent So when you say pre-gestational diabetes was existing long before pre-diabetes, and then pre-diabetes sort of threw that terminology just was thrown in there very recently. So, okay, pre-diabetes is blood sugar that begins to be elevated but without the diagnosis of diabetes. What does that mean? It is defined as an A1C between 5.7 and 6.4. And I usually tell people, clinicians, but also, people, to actually learn those two numbers, because 5.7 and 6.4 being the prediabetes range tells you automatically what is the diabetes range at 6.5, what is the normal range at 5.6 and below. So prediabetes is 34% of the adult population in the United States. So 1 in 3 people has prediabetes in the United States. 1 in 10 people of that group are aware, right? So 9 out of 10 people in that group are unaware. That's the most recent of the CDC numbers. Probably that is improving, but we will not know that for a few more years. So the good news about prediabetes is that it is reversible, manageable through the only things that have been studied. It's probably manageable through a lot of different things, but the things that have been studied are loss of 5 to 7% of body weight, which is often not a lot, and 150 minutes a week of exercise, which is easy to say and hard to do, right? But those are the two things. Nobody said anything about food or stress or sleep, but those are the two things that have been studied in relationships. So the next thing we can define.
Before you go on, I'm actually going to throw a monkey wrench in here and say, sure. I realize that there's another term that doesn't sound as similar, but that I think requires some mention here because it comes up a lot in this realm, is insulin resistance. People are hearing this a lot. And then there's, I don't want to go down this rabbit hole. We can do it on another episode if you're down for it. But when we think about polycystic ovarian syndrome and we talk about insulin resistance, those are times where those words kind of come together. And I think people are hearing them. Can you define what that means for people and why that's different than prediabetes, or if anyone who's pre-diabetic might also be insulin resistant or not? I'm kind of thinking that that's a place where people get confused. A second thought, and then I'll shut up again, is I think people think that when they hear that they're pre-diabetic, they're like, phew, I'm not diabetic, I'm fine. I think people think that. I can't swear to it, but I think that's a thought process. And am I onto something or not?
I hope not. I hope that people don't think it's nothing. It's something. There's a lot to say. An A1C that's very slightly elevated can certainly stay that way for years and years on end, and that's not as much a concern. Flagging an A1C at 5.7 to 6.4 is like saying, let's watch this. And let's do these things that we can do to prevent it from progressing. And in addition to the two I mentioned, there's also metformin, which is getting to be used more and more often for prediabetes.
So I guess I should say that's the problem, I think, on the medical side of the equation is I think I hear let's watch this a whole lot more than I hear let's do something about this. And that's why people walk away going, I'm okay. They said let's just watch it. I guess that's kind of where I was coming from when I said that.
Right. It's true, and it probably needs to be altered, and at least a discussion that is a little bit more, I don't know what the word is, serious.
Well, I think what's happening is doctors, providers in general, we have a tendency to want to smooth everything out, make sure we don't freak someone out. And I understand that's coming from a really good place, but sometimes in doing that, we paint a picture that's like, oh, okay, I thought you were going to say something scary, but then you made it sound okay, and I'm fine. That's kind of the ramification of smoothing it out.
I agree with you. And it's true, there's a discomfort, I think, that some providers have in making people feel not great when they leave the room, even.
Yep. Yep.
So it's an important distinction, and it's important for people to know that you don't want this to progress, and there are things you can do to prevent it from progressing.
Okay, so how does that relate to insulin resistance real quick?
Insulin resistance. Okay, so insulin, there's two ways basically, physiologically, to reach a state of higher blood sugars. And those are insulin resistance and lack of insulin production. Typically, in a picture of developing what is typical is type 2 diabetes, and I mean using the word type 1 diabetes yet, but in the development of type 2 diabetes typically starts with insulin resistance, which has many causes physiologically, which we're not going to have time, I don't think, to deeply get into. But
no, let's not do that.
fat cells and things like that. So insulin resistance means you are making insulin, you are not using it well because you have elements in your body through inflammation, through fat cells, through these things that prevent insulin from binding to insulin receptors at an efficient rate. And when that binding happens, the insulin can leave the bloodstream and the blood sugar lowers. So that happens first, which is, and this is where like checking insulin levels comes into play in the PCOS picture. But the point is the insulin production starts to increase in the context of insulin resistance. That's the first feedback mechanism that the body has. So what happens is if you make more insulin, the blood sugar will get lower because there's now more insulin present, even though there's insulin resistance. Then at a certain point, after usually for type 2 diabetes, years and years, insulin production starts to become a problem. And then the blood sugar can no longer stay normalized because you have the resistance there, you need a lot more insulin, and then you can't produce enough because there starts to be a problem with beta cell insulin production. If that makes sense.
I think that is sufficient for the moment. On some other magical day, we can carry that conversation down the fork in the road. But the reason you said the part I wanted you to say, which is that there's a relationship between insulin resistance and ultimately becoming pre-diabetic. And it's kind of like, maybe I'm oversimplifying too much. There are some stepping stones here, but not with all the terms we're talking about. It's like insulin resistance, pre-diabetes, type 2 diabetes, right? Those stepping stones go together. There's other pathways. When it's type 1, of course, it's different. And then, of course, when we're talking about pregnancy, there's a relationship, but it's more of a side-by-side relationship, right? Rather than like stepping stones. So I'm just trying to give people a way to visualize these terms rather than just seeing them as like a list that they're supposed to be able to make sense out of.
Right. I think that was a good segue into what we've now defined as type 2 diabetes, right, in this process. And that is becoming more common, has been becoming more common for years, right? So that is actually 1 in 10 people in our country, and 1 in 4 are unaware, which is really a large number. So that is those two groups and their non-awareness of these things gives midwifery and OB a tremendous opportunity, because many times people are seeing midwives, seeing OBs as their first line primary care. And so I always encourage people to have A1C at the first prenatal visit in order to find that group who's come to care because of pregnancy, but we know 1 in 4 people don't know they have type 2 diabetes. 9 out of 10 people don't know they have pre-diabetes. So if you do an A1C at first visit, or if you have an A1C at your first prenatal visit, you're going to find out who's who, and not wait for glucola screening, which is much, much later in pregnancy.
Okay, so then there's also the conversation of who should have the glucola screening at their first or maybe shortly thereafter visit.
Right. That is a whole nother conversation. So that is gestational diabetes screening. So if you've at the first visit done the A1C, then you've put prediabetes and type 2 diabetes either on or off the map. Right? Because you either have an elevated A1C in the diabetes range, you have an elevated A1C in the prediabetes range, or you have a normal A1C. So you've at least kind of segregated those three groups. Then for the people with diabetes range A1C, you're not going to give them glucola. Instead, they can check finger sticks. They can do all the things that hopefully get a continuous glucose monitor, all the things can be, I know, you and I will have to talk about that at some point in this conversation.
Yes.
Yes. And people with that prediabetes range A1C then should, even in the absence of other risk factors, which we'll talk about in a moment, should get early glucola screening because, right, they're coming in with some element of higher blood sugars. And then there's the group of people for risk factors. Even if the A1C is normal.
But I feel like that's another big, here I am just like, tearing apart our medical system. That's the next big miss. It's just not done. I can't tell you how many times I've come across people late in pregnancy and I take their history because I'm going to help them through postpartum. And I'm like, ruh-roh, this person should have had X, Y, and Z.
Right.
It's crazy. Why can't we get with the program? What's the problem?
Well, I think the list is pretty long. So what I encourage people to do is, instead of trying to remember what's on the list of risk factors, and this is not to over-pathologize people, please. It is to think if this person doesn't have any risk factors. The other way around, because almost everyone has risk factors, right? So it's an elevated BMI, it's a history of any kind of dysglycemia, any kind of elevated A1C, any kind of elevated blood sugar on a chemistry, and any kind of gestational diabetes in the past. PCOS is definitely a risk factor. First degree family relative, although 2 second degrees probably as well. Lack of physical activity is its own risk factor. So there are many, and in my world there are more. And so I do encourage people to, instead of thinking what are the risk factors, I mean, you should think about those anyway, of course, because they have many ways that you can address them. But it's think who doesn't need to have early glucola. I think most people do, or can benefit from having it. So we have gone into gestational diabetes without really defining it. It's actually defined as any high blood sugar that is recognized in pregnancy. So, and I will say it is caused by placental hormones. Specifically, and most commonly, it's caused by progesterone and placental hormones that are really increasing towards the third trimester, which is why the standard time to use glucola to check for diabetes is between 24 and 28 weeks. This is if you have gone through the whole beginning part of pregnancy without having risk factors, without having a need for early screening. And if you did have early screening and it was in range, then you would have it again at the time that the placenta is rapidly growing between 24 and 28 weeks. So that, and I would say though, people who have it early, I would call, if they have a normal A1C, I would call that early onset gestational diabetes, not prediabetes.
Okay, I totally need to unpack that.
I'm sorry, not pre-gestational diabetes. Woo, I'm sorry. I even messed up my own terminology. Okay.
Say it again, because then I think I have no, I want you to repeat it so that it's said clearly, but I think I have a question as a provider for you. Like I'm raising my hand in a classroom.
So gestational diabetes is high blood sugar meeting criteria for diagnosis of hyperglycemia in pregnancy. So I call it early onset gestational diabetes when I find someone in the earlier part of pregnancy, presuming they have a normal A1C. That is not pre-gestational diabetes. That is early onset gestational diabetes.
All right, so here's where I'm running into some trouble, and maybe I'm operating on some old or inaccurate knowledge. You are being very intentional about not attaching gestational age to what we would call, we haven't defined it yet, sorry guys, we'll get there, a pre-gestational diabetic or a gestational diabetic, whereas I feel that I've always known, in air quotes, whatever that means, however I came to this knowledge, that if we diagnose high blood sugar prior to 24 weeks, then that person was very likely a pre-gestational diabetic and we missed it. That's what I was always taught. And so that's why I've always been neurotic about being that person to figure out who needs proper testing early, because I don't want to live with the uncertainty of what someone is or isn't. Am I making sense?
Yes, and I've definitely heard that and know that to be a philosophy. I think my philosophy is if you have an A1C at the first visit, you've put people on the map of whatever is pre-existing. So they either have no pre-gestational hyperglycemia if the A1C is 5.7 and below. They have pre-gestational, wait for it, pre-gestational prediabetes.
Woo, that's
early
crazy.
Pregnancy. I mean, you can't make it up.
Nope.
It's pre-gestational prediabetes if they have an A1C of 5.7 to 6.4 in the first trimester, or I say before 20 weeks.
Okay.
And then,
thank you.
But I mean, I might have made that up. I don't know exactly where that moment is where we take that A1C and say it's part of the placenta.
I don't think we have to know where it is, right? I think it's okay to live in the gray. We midwives are very comfortable living in the gray. I think the place that's most critical is if we see evidence of something early in pregnancy. I'm not even going to try to define what I mean by early. But if we see evidence of it, we have to say, this didn't just turn on like a light switch. It has been there. Therefore, it is very likely pre-gestational, not being caused by the stress of the pregnancy. So while I'm at it, I'm going to say out loud, and you can always tell me if I'm saying something wrong, because this is not my absolute expertise. It's just my interest. What happens in pregnancy is that pregnancy is inherently a state of becoming insulin resistant, even for the most healthy person. And that's something people need to understand.
Yes. Okay. It is. It's such a good point. It is everything that happens with glycemia in pregnancy has to do with insulin resistance and has to do with the placenta. It is what it is. I mean, unless you want to say the corpus luteum that's producing the hormones for the first 12 weeks, right? That is actually, for people with type 1 diabetes, that is actually an issue when that corpus luteum dissolves. And before the placenta takes over, there's an insulin sensitivity, opposed to insulin resistance. The opposite is insulin sensitivity. That is this dip between 8 and 18 weeks when the corpus luteum is gone and before the placenta is starting to take over.
Meaning you need less insulin at that time as someone with type 1 diabetes.
Yes.
Okay,
everyone
cool.
Technically does.
Everyone. I got it.
But all the other bodies are magically just not producing as much.
Right. They're just dealing with it on the fly, and we don't really have to think about it. Got it. Okay.
Yes,
Cool.
exactly.
All right. I promise to shut up for a few minutes and let you go back to pre-gestational diabetes, and I'm going to try to behave myself.
Okay. No. I love you're really good at your questions, and you're really helpful to somebody who sometimes I can go off.
No, I think you would be very organized if I would just shut up.
No.
All right, carry on.
Okay. So then type 1 diabetes, which is the one that you're going to most rarely run into is the least common, and it is unrelated in a certain way to all the other diabetes, because it is an autoimmune disease in which there is a genetic disposition followed by a cascade of antibodies being produced, and they are antibodies that attack, not a very medical term, the beta cells sort of all at once. And there is typically something that happens in childhood, although 50% of people diagnosed with type 1 diabetes are diagnosed in adulthood. So we don't use those terms anymore of juvenile diabetes or insulin-dependent diabetes. We don't use any of that. It is type 1 diabetes. 50% of people get it in childhood and 50% of people get it in adulthood. It is still the least common, though it's becoming more common. A big mystery.
What is the earliest age that someone becomes noticeably having type 1 diabetes?
Having type 1 diabetes. It can be in a few weeks to months old.
Oh, it can be that early.
There is neonatal diabetes, but it is usually not type 1. It is usually a different cause. I only know this type of unusual diabetes from working in a diabetes-specific practice. But in general, it can be in a few months. And usually those babies are born with antibodies already. So, but I think the most common time is actually, I want to say 14 is the peak. It's like puberty, really, is the most common time, where it peaks and then it sort of declines. So in any case, pre-gestational diabetes, which I also think was poorly named, because it really takes away how people called themselves all their lives, and they have to take on a new name when they become pregnant. But really, it is either pre-gestational type 1 diabetes or pre-gestational type 2 diabetes.
Yeah, it's totally redundant. It's totally redundant. Yeah.
I think people wanted to put it all in one category, which, people with type 1 diabetes don't like that. But in any case, people with type 2 diabetes probably don't like that either. And it's not appropriate. But in obstetrics, the name of the game is the blood sugar. And so for them, it's like simplifying it by just saying, okay, this person had diabetes before we met them. The goal is normal blood sugar. It doesn't matter what kind of diabetes they have. But it should be said that the complete diagnosis in pregnancy is pre-gestational type 1 diabetes, pre-gestational type 2 diabetes.
Okay.
Are you pregnant or a new parent looking to ensure a better postpartum experience? Or are you a birth worker looking to improve your postpartum care skills? Check out Thriving After Birth, an online self-paced course by me, midwife and educator Tanya Tringali. It's 10.5 hours of video content featuring experts in lactation, mental health, pelvic floor health, pediatric sleep issues. You also get worksheets and a workbook, as well as options to have a one-on-one session with me. Sign up at motherwitmaternity.com/thriving, and let's improve postpartum care together.
We hope you're enjoying the Mother Wit podcast. If you are, please rate us and leave a review in iTunes, Spotify, or wherever you're listening to your podcast. Thanks so much. Now, back to the show.
I've got one more question.
Yes.
We've been defining these, particularly, the categories of pre-diabetes and type 2 diabetes, excluding type 1 from this comment, by A1Cs. Can we also define these by glucose levels? And why or why not should we think that way?
You are so clever. I could answer that question in 2 minutes or in 2 hours. Okay.
I'll take the 2 minutes.
So let me try the 2 minutes. I'm going to try. It's going to be hard. This is such a good question. A1C has existed for probably close to 30 years. It was only adopted and used to define prediabetes in the last less than 20 years. less than 20 years. Up until that point, blood sugar numbers, blood glucose levels from blood drawn from someone's arm in the lab was what was used. And people were, fasting was done, people were given the glucola drink, and then blood sugar was checked at 2 hours. This is the same test we use for postpartum people who had gestational diabetes. That between 4 and 12 weeks, they should have that test. Why? Because the A1C is not relevant when you've just had normal blood sugar for the last many weeks of your pregnancy. So the A1C is going to pick up that time period. And it is not relevant in the context of acute blood loss, which happens at birth, and various other things. So those are the two main ones, though, and why we need to use actual blood glucose tests and glucola for the postpartum people. And yes, that can be used as a way to diagnose both prediabetes, and there are numbers for this. I can tell you what they are, but it doesn't really matter. There are numbers for prediabetes, and there are numbers for overt diabetes for both the fasting and the 2 hour. There's no 1 hour. Fasting in 2 hours. It's not used because it's a lot easier to do in A1C. That is the reason it is not used. And you don't have to have people come in fasting. They don't have to drink the glucola, etc. However, more people are diagnosed using the actual blood glucose levels and the glucola, which is called the OGTT, oral glucose tolerance test, than with A1C. If that makes sense. So there are a certain group of people that you might do that on if you are very much thinking they might have diabetes, but their A1C is still normal. That's a very small number of people, though. I don't want people to go down the rabbit hole thinking about that.
I think what I'm thinking about to make this a little more practical when it comes to whether we're talking about preconception care or interconception care or just straight up primary care for the years that we are not having babies is that I'm thinking about the tests that are routinely run on just about everybody who seeks out basic primary care. And most people will have some blood work done fasting, and that's primarily to get a handle on our cholesterol levels and check out what your fasting glucose is. So if somebody goes to their primary and they get a fasting glucose and a hemoglobin A1C, what should their care look like after those results are back if they aren't perfect?
Such a good question. And that does happen actually quite a bit. That people will throw in a complete metabolic panel with a lipid panel on someone who's fasting, and that fasting blood sugar could be, 101 and the A1C is 5.6. Is that of concern? I think it's an overtime question. That's my quick answer. I think it's an overtime question. Okay, it's like, oh, right, that's interesting. I don't think that means get a CGM. Have people gotten a CGM for that? Yes. Continuous glucose monitor is a CGM. Have people checked blood sugars after they saw that? Yes, people have. Would that be recommended on a population level as a useful thing to do? Probably not. I would look at the person's hemoglobin and hematocrit to make sure that they don't have like some really significant anemia that might lower the A1C artificially. I would probably do that. And also like there's various other things that can lower an A1C. If you were really concerned, then you could do an OGTT and have them come back again. You'll get a second fasting number. Then they'll drink the glucola and they'll see what the number is at 2 hours. If it's in that 100, low 100s, I mean, that is prediabetes through a method of, it's not a method. It's called impaired fasting glucose, IFG. So that is the thing. What can you do about that? Probably
Lifestyle.
The sky is the limit. Yeah, if you're stressing over that result, I would say the better use of your stress is to probably take a look at the lifestyle issues and the things I tell people in pregnancy, and this is segueing into a whole nother conversation, but many people have just that, the elevated fasting. And in some ways, because they're eating relatively well in pregnancy, they don't have huge jumps in numbers after food, and they just have that elevated fasting. And the things that can help that are really eating earlier, having a longer fast. We know about intermittent fasting, right? That's a thing. It doesn't have to be intermittent fasting like you're fasting for 18 hours. It could be for you just maybe it's 12 hours that you stop eating a little earlier and then you let that fasting come down. Exercise, of course. Good sleep. Sleep cannot be underestimated as a factor specifically in, well, I don't know, it's specifically in all blood sugar, but it is a factor in elevated fasting to have poor sleep.
Yeah.
It's also a factor in the other numbers because when you're sleep deprived, you want to eat differently and eat more, and the blood sugar will also be higher after food, but it will definitely be higher fasting with poor sleep. So those are some basic thoughts that you might be worth considering.
I love that. In my postpartum program, when we're wrapping up at our last visit, one of the final things I talk to people about is their health care from that point on, because
yes.
I find that the time that people accidentally opt out of routine preventative care is postpartum, because they were just seen so many times, and then they had that postpartum visit and they just don't even know where the reset button is, right? So I talk to people about, well, when did you see your primary care physician, if you have one, or a primary care nurse practitioner or whomever, midwife,
right.
whomever, when did you see that person for the purposes of sort of a primary care preventative care check-in? And I get them to think about it. And then regardless of what the answer is, right, depending on when it was and what they can remember and where we're at with their care at that, 12-ish weeks postpartum point, we find the appropriate point to say, this is probably when you should put on your calendar now that you're due to go back in and get all these things checked out. I just want to get people on a pattern of awareness. So one of the things you started out talking about is the sheer number of people that don't know. And I actually wonder if you can unpack the reasons people don't know more, right? I'm assuming, making some big assumptions here, but that I think are probably correct, but there's just probably more to add. It's access to care, it's poor care, it's all the things. But so tell me more about that, because our goal here is to get people to find out where they stand in this spectrum.
Absolutely. I'm nodding my head. Since you can't see us, I'm nodding my head rapidly here. Yes. It's so important for people not to, quote unquote, fall off after they have a baby. And it is the easiest time for them to do that. They have a newborn they're taking care of. They're stressed. They have all the things. They have things they probably put off because of the pregnancy. And this is so common. I would say that, one of the things I've done to address it specifically is I have a video visit at 3 weeks. This is in the public hospital world, which I so appreciate what you do, Tanya, because it's like you're there for people to remind them of that. But I don't think there's much of that in place.
No.
So is having a video visit at 3 weeks, and it depends on the person. There are many people that I see a number of times after that who I'm worried about them falling off. And so I'll make another appointment in 4 months or so to just call them and check in. But at every single time we talk about what can be done if the person has gestational diabetes, what can be done to prevent the development of type 2, which we know is at least 50%. It's hard to really get good numbers on that, but it's at least 50% of people with gestational diabetes go on to develop type 2 diabetes. So how can you be in the 50% that does not? And the most we get down to super basics at that visit because there's so much going on, and we're talking about breastfeeding and contraception and stitches and bleeding and blood pressure. And we talk about not drinking your food. I can't believe I've gotten this far, without saying that. I am a big believer in do not drink your food, eat your food. Your food needs to be chewed, starting in your mouth so that you can start the physiologic process of digesting it and of producing insulin. But that
let's unpack that. No, I think we should unpack 1 second. I'll say one thing and then you can add another thought and we'll leave it at that.
Okay.
I think people need to know why, because it's such a great point and people I think instinctively go, oh, okay, I get it. But then if they thought 1 second longer, they might not be able to answer the why on that. And the why is fiber. Fiber.
Fiber.
If you juice your apple and you only drink the juice of the apple, you just got hit with a massive amount of sugar. But if you eat the apple, the fiber offsets the sugar. That's the simple way I'm going to put it. You want to add something to that?
Yes. And in addition, I do think there's a process of where the food physically hits in your body. If it's starting in your esophagus, you've knocked out your system and your possibilities of getting the insulin production going. And I think if you're chewing, first of all, that apple takes a while to chew. And the saliva, I'm not an expert.
That's fine.
But, the saliva is produced and it signals that there's food coming, right? It is an enzyme of your GI system that is starting the process, and the insulin production is related to that. So it just gives more time for the body to do what it needs to do to produce the insulin it needs to produce, even if it's the exact same amount of insulin, even if you didn't have, which it's not because you have the fiber, that it's a timing issue as well as the fiber issue and the reduction of carbohydrate issue. So it's like the one most important thing that I think otherwise, if you do so, the people learn so much during pregnancy with gestational diabetes. There's no way it's sustainable. And so I'm always thinking about what is sustainable, even during pregnancy, what is sustainable? Small changes for big results. Small changes for big results. So much can be done with such little change.
I love you.
But if you do one thing, it's that.
I agree with you. It is absolutely the first change I encourage people to make. People should drink almost exclusively water. And it's okay to have some coffee and an occasional glass of whatever. That's kind of where I leave it with people. But sodas and juices, you gotta be done with those. Because not only this whole process that we just talked about fiber and insulin and yada, yada, liquid calories end up accounting for some of the excess weight that contributes to this, right? Yes. So when people are coming from the mindset of weight loss, which often overlaps with prediabetes and type 2 diabetes, we can kill two birds with one stone here.
Yes.
I mean, it's just a beautiful thing. So anyone listening who's trying to start this journey, this is probably the most critical take-home message is don't drink your sugar or your calories.
Yes. It's like the only non-negotiable. And you know what another opportunity is with it? We can't change the genes we have in our body. Diabetes is genetic. All diabetes has a genetic component, all of it.
Yep.
And we cannot change that except to not have children. If we're going to have children, we're going to give our genes to our children. What we can manage is what's in our kitchen. We can't even really manage what's at school or what's at a birthday party, but we can show our children what's in the kitchen. And for children to not drink juice and not drink soda is going to prevent diabetes, type 2 diabetes specifically, in them. Yeah. And that's huge.
Yeah.
And not to mention the other things having to do with drinking a lot of calories, which is, weight issues and things like that. So critical. If you have energy left in you, then you can talk about moving your body, which is that's my second thing, is find some way, and it doesn't have to be any specific way at all. People don't have to leave their house to move their body. You can put on one song. I used to say 2 songs. 2 minutes. 2 minutes of moving your body after you eat affects your blood sugar. 2 minutes. I've always thought of it as this minimum.
Oh,
of 10
absolutely.
minutes. 2 minutes. So don't drink your food, move your body. Breastfeed, if you can, for 1 year. We finally have shown what is so logical about that, because we know about the metabolic state of breastfeeding, right? It is very similar when you think about it in terms of blood sugar. It is like you are on the treadmill basically for the entire time you're breastfeeding, right? In that metabolic state. And so it has this positive effect on blood sugar. So we finally showed on a population level, this was in Kaiser, in tens of thousands of people, that the reduction of type 2 diabetes that happened after people breastfed for a year. So that one. And then seeing a primary care person and actually making that appointment for them, because following up and making sure that, and understanding what is the A1C, always mention that you had diabetes in your pregnancy to your primary care person, and so that they know to check an A1C. And the official guidelines is between 1 and 3 years. I tell people every year, basically, because they're more likely to have it done within 3 years. But to follow it, because I now been doing the perinatal diabetes long enough that I have seen people come back with their second and third pregnancies and babies, and very, very often they have gone from having a perfectly in range A1C to a much higher one. Most often, I would say.
So now you're touching on, this is like a semi-unrelated thought, but I think you'll get where I'm going with this. There's also all this hard data that, we gain a little bit of weight with each pregnancy on a population level that we can't get rid of. So, when somebody has their first baby, even if they're normal weight, and they lose most of it, it's very common for someone to never see the weight that they were before that first baby ever again. And then we see that happen with consecutive pregnancies. So in the ballpark, I don't have the research memorized or handy, but in the ballpark of retaining 5 pounds from each baby. And that's going to be a contributor over the long run, which harkens back to what you said before, that something as simple as, and I oversimplified just by saying it that way, but of losing 5 to 7% of body weight can get you back out potentially of that pre-diabetes stage. Imagine what we've got going on when we've got an aging process happening and when we've got childbearing sometimes repeatedly happening. It's sort of a double whammy.
Yes.
Right?
Yes. Do you want, and the third whammy in the context of right now is COVID. And what we are seeing is much higher rates of, actually, I'm sure type 2 diabetes is in the equation somewhere, but much higher rates of gestational diabetes and higher rates of type 1 diabetes since COVID. So we can attribute some of that to, of course, inactivity and the overall weight issues that people have had to struggle with during this time. And I don't know what explains the type 1 diabetes thing, but it's another thing that is really currently a problem.
Wow, it's really interesting because it makes me think about how varied long COVID can be and all of these things that we don't yet understand, and it just kind of feels like it fits into that very broad bucket. Mm-hmm. But yeah, cool. Is there
people need more support?
Oh yeah,
people need more support. Yeah. I mean, I fantasize about having more group care and postpartum care. We're actually working at my public hospital and having a lifestyle medicine practice. And, there is a lifestyle medicine certification that I'm planning to do. But to have a lifestyle medicine practice that can specifically serve people after they've had any kind of diabetes in pregnancy, so they can continue to have the support. They have tremendous support during pregnancy. And then our example is, even though we're telling them to continue to take care of themselves, we're not there for it. So we're not there giving that support, and we need to be. And so we need to have intensive lifestyle management options and support for people after they are pregnant, in between, not even talk about pregnancy. The adult needs this, so it's really important, and I'm inspired to get involved in that.
Well, on that note, I would love it if you would tell everybody a little bit about the work that you do on your own outside of your, full-time job in the hospital system, because you're doing some really beautiful work and you're flexing your entrepreneurial muscles. And these are the midwives that I'm so happy to have in my life, because you guys understand, kind of what it is I'm going through, and I understand what you're going through. So tell us all a little bit about what you've been out there creating.
Oh, you're too kind, Tanya. My entrepreneurial muscle is like, I'm picturing like the one neuron in it. A tiny little muscle that really needs to go to the gym. So it was born out of really the undeniable need to serve people with type 1 diabetes who still don't have what they need. And there's no one else really to give that to them. I am uniquely in a position to do that. And so what I do for them is a course that is a 12-week course, and we also meet individually. And then with this last group, which was so great, we combined people from past who are mothers with type 1 diabetes who came to the group. And now that is a new group of people who are, I'm sorry, did I mention that it's preconception? The idea is starting with preconception, right?
Tell us about the structure of your program and who it's for, and the structure of your program and all that, Jess. Give us the details.
Okay, so my current up and running program is a 12-week course for people with type 1 diabetes in the preconception time period, because there's really no one to serve them, and I'm uniquely qualified to do that. And so we do a group for 12 weeks that involves them meeting each other, and we have topics week by week, and then I have one-on-one sessions with them as well. And then we incorporate them with a larger group of mamas with type 1 diabetes who have been through the whole process before. And it is, it's an amazing thing to bring people together like that, because the groups are very validating, and very few people have had the experiences we've had. So it's a special thing. And in addition, I'm working on some education that is going to be online for people with gestational and type 2 diabetes, which we know is also a big group of people who are at times searching for additional services that are missing from the standard medical care. And it really is about being holistic and looking at a whole person. So it's more than just high risk OB and endocrine, as I started to say at the beginning. It is about where people are in their mindsets, where people are as far as their basics of their lives, their exercise and their sleep and their stress, and how we can work together to optimize things, because every person can benefit from midwifery care.
Yeah, totally. I love that we just keep saying that over and over again. But what you are saying that I think is really beautiful, beyond like midwives are awesome, which is true, is it's what you're offering is community support, education, and healthcare kind of all wrapped into one. And that to me is the future of healthcare. That's so much of why I do things the way I do. And you're doing, you have a different, unique, and you have a narrow focus on something in which there is just such incredible need for someone to do what you're doing. But we can't keep putting healthcare in like, you know, a narrow lane and leaving out all those other pieces because it doesn't work. We've seen it over and over and over again over the decades. It doesn't work. You can't deliver just one piece of these things. So anyway, while we're...
We have to really like...
Go ahead.
Sorry.
Yeah.
But I think of this visual image of, here are the guidelines, which I well know, and here is the clinical experience, and here's the human being. And it's really finding where all those things overlap, putting the human being at the center, of course, but finding where there is a safety in where the three things overlap.
I love that. I love that. All right, as we move towards wrapping up, we have hinted a bunch, and I have in many episodes hinted a bunch and still just never really done it, talked about this whole CGM thing, which I'm super passionate about, and you are too. So I think you're the right person to just take a few minutes and unpack who a CGM is truly indicated for and what people privileged enough to get their hands on one and afford one might do with it and why. Like, let's just have a little bit of a conversation around this because I think some people really get it. There are people out there that are like so super healthy and so super fit and they're obsessed with their CGM. And you know what? Good on them. I'm glad you have the resources for it. Meanwhile, I myself, just to be very clear, I have worn a CGM 3 times for 2 weeks each time because I can't afford it. Right? Like, and I don't know if I've ever said this on the show. I have polycystic ovarian syndrome and I flirt with insulin resistance. And anyone who knows me knows how much I exercise and how hard I work to eat well. And I still am on this, you know, place where I'm flirting with this. So my interest in CGMs is very personal. And yet I'm not one of those people that wears a CGM all the time, despite how much I like rave about the CGM. So I want to put this on a continuum of like, who really needs one? And what the other end of the spectrum looks like when we are looking at the pinnacle of wellness, right?
Such a good question. We're going to hear more of these questions and more answers. In my world, you know, I'm about removing barriers for people, and I work in a world where people have not had access to CGM, who desperately, I didn't say desperately need, but would benefit on such a high level from CGM. And so I spend a lot of energy trying to bring that kind of private institution care to the public. And I can tell you that Medicaid, the Medicaid plans are paying, they've changed their payment as of April of this year and are now being a little bit more lenient in terms of what they'll pay for. But historically, it's been people on insulin, specifically on what's called basal bolus insulin. So basal insulin is for your basal metabolic state. Bolus insulin is for correction or for coverage of meals. So it usually means 3-4 injections of insulin a day was required to get CGM coverage. That's hopefully going to change so that more of that group can have CGM. As far as people who are not on insulin, I think it's about what can people learn from it. And there's a lot to learn. There are many people who go on it for 10 days, 20 days, 30 days, and they see what happens in that time period, and they see certain patterns just within that time period that they can then translate that into what they're going to do in the long term. And I think that's really, really valuable. One of the things and so hopefully insurance will get to a place where they might say to, you know, everyone with prediabetes, an A1C 5.7 to 6.4 could have a 90 days of CGM, for example. And learn from it, but it takes help to learn from it too. You can't just, it either takes a professional looking at it with someone, or better yet, the person who's wearing it taking notes on what's happening, because you can't see what's happening in someone's life just by looking at their blood sugars every 5 minutes. You have to ask how that coordinates with what they're doing. So it's more important for them to have the mindset that they want to learn what the effect is of what they do on their blood sugar. And then I think that it can be useful. I do think that we can't ignore the fact that the alerts and the alarms world is real. It's real. People who have these devices lose sleep, increase anxiety, increase things that are counterproductive often to blood sugar. So if you're the type of person who is going to be, watching over it on a level that's preventing you from sleeping or that's causing you stress, then that might not be the right thing. And I know it's really hard to assess that in yourself. That self-assessment is hard because it's oftentimes those same people who think they're going to benefit from it. I'm not doubting that I don't want to doubt them, but who propose benefit from it and yet might also have some negative effects of just the over attention paid to it.
Sure. I get that.
That makes sense.
It does. It totally does.
And it's not covered for them. So,
right. And you already kind of said this, without support, it doesn't help much, which is why some of the companies that are out there, these health tech startups that are doing really cool things, it's the startup a little bit more than the device sometimes, because without that intensive information and without treating, if you have to be really willing to treat yourself like a science experiment where you only have a sample size of 1 and you have incredible bias because it's your own body, right? So
right.
You can run, what I talk to people about who are doing this is, okay, so we saw what happens when you eat this amount of this thing at this time of day, having slept this much, with this much stress and all the factors. Just because you run that experiment again one more time, we still don't know all the things because there's right. The interplay of too many variables: stress, sleep, illness,
yep.
Yada, yada, yada. So while it's super cool to sit down and watch and we can be like obsessed with data, it takes a long time, and yet it's really hard to stay that invested for that long. So people, I think, have to be in a particular mindset when they are gonna trial it for periods of time, and
and it's also been shown that people, like a normal person, normal people have some high blood sugar sometimes. So, and that is perfectly tolerable to the overall systems of the body. And I don't want to, say that everyone could be like, 200s at times or whatever, but it's been noted that people go to 180 who do not have diabetes and who have normal A1C. So I would say it might be more about the person who is in that pre-diabetes range to try to glean some value in their relationship between what they're doing, what the blood sugar is, to try to cut those little mountains down a little bit.
Right. And what I want for the world is not so much that everybody is walking around wearing a CGM 24/7 for the rest of their lives, but rather something that looks a little more like it's, that panel of blood work we talked about that's the current standard, that maybe a 2-week use of a CGM and a motivated person who's willing to take notes on their activity and their diet can say 2 weeks prior to my yearly checkup with a provider that's well versed in preventative medicine, which is not the same thing as just saying primary care. I would like to put in the work and the effort to see where I'm at this age, at this weight, at this current lifestyle with how much I work and how much I sleep, so that I can see if there's a tweak I'm willing to make to reach some optimal level of wellness, whatever that is for someone, right? I just want people to take the power back into their own hands and define what level of wellness makes them feel good about themselves.
Love that. Love that. Hear, hear.
So
And if there
anyway,
weren't so many barriers, the other thing is like it's a real process to get these things.
yeah.
So I wish there weren't those barriers for people, because I think to get coverage is...
Yeah. But I think we'd have, I hate the word compliance, really, that's a horrible word, but I think we would see people doing better with the 4 times a day finger sticks or whatever the case may be if they just were wearing a CGM, right? I think we could just do better in general for people because it's so much less taxing. Anyway, whatever. We could talk about this forever, obviously. But I just wanted people to hear us kind of banter a little bit about the idea of it and kind of get a sense of what it is and how we feel about it and why. And I'm sure that this is going to be evolving greatly for both of us over the years to come as we start to see more data, because again, these healthcare startups are well poised to give us a lot of data in the next few years.
Yes. And I look forward to it. I think it's going to be helping a lot more people.
Yeah, totally. Anyway, is there anything else that we kind of skipped over because I was way too enthusiastic about talking to you that you we're like dying to tell people and we just kind of were remiss? I want to give you a chance to add anything in.
I mean, I'm thrilled to be here and be able to talk about diabetes that affects half of our population. And I am thankful that you see it, how it fits into this much bigger lifestyle picture, because I see it that way too. As much as I love insulin, I also think that the lifestyle piece is so important for everybody. So
well, absolutely. And what you just said
thank you for also acknowledging that.
Oh, my pleasure. I'll make an analogy to what you just said, and that is, it's kind of like saying midwives love catching babies, but we also really love preventing pregnancy when that's what someone wants, right? It's like you can have both at the same time. Yes. I love that analogy. Well, I look forward to you creating more products and services and groups and all the things you're doing. And I will be sharing you with my audience every step of the way because your work is so special to me. Thank you so much for taking the time to talk to me today.
Oh, thank you so much, Tanya. What a pleasure. And I will look forward to the same with you.
Awesome. Thank you for listening to the Mother Wit podcast. If any of the issues we discussed today resonate with you or your experience, I'd love to hear from you. Leave me a voicemail at 917-310-0573, or better yet, email me a voice memo at tanya@motherwitmaternity.com. I really want to hear what worked for you, what didn't work, what support you'd wished you had, how you got through the tough times, how you advocated for yourself, or especially any tips you want to share with our listeners. I want to hear all of it. And if you'd really like to work together, you can get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. Okay, that's all. It's wonderful being in community with you all. Thanks again for listening, and see you next time.
And remember, listeners, nothing we discuss on this show should ever be considered medical advice. Please speak to your local provider about anything that comes up in this show that resonates with you and your needs and your health care.